who have just joined. So it's exactly 5 p.m. in Geneva, and we are going to start with today's lightning chat. So a warm welcome to you from the Geneva Learning Foundation. I am Charlotte Mbuh, and my guest for today's lightning chat is Carolina Danovaro. She is a medical epidemiologist at the World Health Organization headquarters in Geneva, Switzerland. And we all know you are busy professionals. That's why we invented this lightning chat. It takes just about 15 minutes of your time, and we only extend if you have more questions about the topic at hand. You can decide if this topic is important for you. If it is relevant to your work, you will have the necessary links to learn more. Carolina's topic for today is data enabled, making this a reality. And it's all about IA20, that's Immunization Agenda 2030. I'm going to ask Carolina the first few questions, but I will be looking to you who are here in the Zoom studio with us to ask your own questions using the Q&A button, or you can also share your comments in the chat. You may also want to raise your hand if you wish to speak. I'll be delighted to give you the opportunity to do so. Maintenant, pour les participants francophones, il y a l'interprétation simultanée, donc vous pouvez cliquer sur l'icône du monde en bas de votre écran pour suivre les présentations, mais les échanges en langue française. So I was just saying for the benefit of our French speakers that they just need to click on the little globe icon at the bottom of the screen, because the chat is going to be interpreted simultaneously. So I want to wish a warm welcome to you, Carolina. We are going to go straight into the lightning chat. But before that, please, Carolina, would you like to introduce yourself? Tell us who you are, where you work, what you do.
Thank you, Charlotte. Thank you, everybody. My name is Carolina Danovaro. I'm a medical doctor and epidemiologist, and I work with the Global Immunization Monitoring Team in the Immunization Vaccines and Biologicals Department in WHO. There, I'm the focal person for surveys, and we do the global estimates of vaccination coverage also.
Okay, thank you very much, Carolina, and thank you for accepting our invitation today. Now, here is question one. We will be asking this question to every one of our guests. We know that in countries, many EPI staff have begun to work on IA2030 to inform their new national immunization strategies. Can you tell us, when it comes to data enabled, what is new or different with IA2030, and why does it matter? Over to you, Carolina.
Okay, so there's a new decade, a new era where really we are all much more exposed to data, and I think there is a better understanding of the importance of data to help with our processes. Sorry. So I think what is different is the availability of accessing data, the digital capabilities we have, and also, again, the understanding that data, not only for immunization, but in our daily lives, can really help us make a difference. So it's a new era. There is new evidence also that suggests that the use of data can really help streamline processes and can really help us make better informed decisions. So a lot of new things around us in our context that can help us in our immunization programs as well.
Okay, thank you very much, Carolina. My next question: over the past 2 decades, the quality and use of immunization and vaccine preventable disease surveillance data for decision making have been highlighted in global agenda. From every indication, this continues to be a major concern. So why do countries need quality data? What needs to be done differently during this decade to ensure data quality improvement and use?
So in 1998, so many of you were children probably, the Strategic Advisory Group of Experts, SAGE, of WHO already started discussing data quality for immunization. So this is really not new. It's something of over 20 years that we have understood that the quality of immunization data, it's a problem. We also hear about the bad denominators, etc. But I think what is different is our understanding now that the more we use the data, the quality is going to get better. So instead of trying to wait and try to help and fix the quality of the data first, really our better approach is to start using the data more, because that in turn will help with the quality. And also the quality defined as something that is good enough for purpose. So it doesn't have to be perfect, but for example, if you're at the local level, you can really, what you need to do is to know who is your defaulters, to really go track them. What are your communities, to make sure that those communities are reached, for example, if they need to be reached by outreach. For surveillance, we of course need to understand the vaccination status of the cases, that sometimes it's missing in some of the forms. So what's different really, it's the use as the main driver of quality and not the other way around.
Okay, thank you so much, Carolina. And if you're just joining us, today we have as guest Carolina Danovaro from WHO headquarters in Geneva, and we are talking about data enabled and the Immunization Agenda 2030. So please feel free to ask your questions around this topic to Carolina in the chat. Now, for our next question, usually data collected at the local level is considered the resource for levels higher up in the health pyramid, and hence little attention is paid to data quality or data use. So what can be done to change this trend with IA 2030 in order to enhance the use of quality data at the local, or what we commonly call the health facility level, because that's really where the difference is being made as far as reaching target populations is concerned?
So I think that, again, things have changed. I think there is a better understanding of, sorry about that, of the importance of the local level data to make decisions at that level. So it's very disappointing. I was doing once a supervision and I hear the person say, oh yeah, they gave us this new information system so they can control us better. And I was thinking, no, the idea was really to help the local level with tools that help them, or you in this case, if you're at the local level, plan your sessions, plan your supplies, make sure that you have what you need and that you know who is your target population and you are reaching them.
Okay, thank you very much, Carolina. I'm just turning towards the chat to see, my eyes are on the chat to see if there are any questions from our participants in the room. Maintenant, je vois une préoccupation de Ahmed Abdali qui demande la traduction en français. Donc, je sais qu'il y a une icône en bas de votre écran, une icône qui ressemble un peu à l'icône du monde. Si vous cliquez dessus, vous aurez accès à la traduction en français. Donc, nous sommes là aujourd'hui avec Carolina. We are going to continue our discussions with our chat with Carolina Danovaro. And I see we have a first question here in the chat from Amel Altai, saying, in 3 countries where I worked, huge data is being collected but not really used for actions. Is there a specific focused area in IA 2030 to make sure that data is used for action at country level? And Carolina, I see her question is in line with my previous question. So can you maybe throw more light on this for the benefit of our peer, Amel Altai?
Yes, so I think there's a whole lot of data being collected, and sometimes we collect data that we don't use. Sorry, I'm in a noisy place. So one of the important things here is to really understand what is the minimum data we need, and if that data is fit for the purpose where that is collected. So let's say numerators. I think that's one of the key elements that we need to then calculate coverage. But at the local level, that's a tally that you don't really need that much other than to meet goals, etc. What you need more is the books, all the registries where you have the name of every child, or the tickler files where you have cards with the copy of the information of the child, so you can really see the next month who is your target people. One of the key factors that help reduce missed opportunities, for example, is having good vaccination cards. So the data that gets recorded in the person's card is one of the main and basic needs that sometimes we don't think about it as it required data. But having the complete and accurate vaccination cards is not only useful for the person to come back and to make sure that the health worker also know what vaccine to give next, but also in surveys. So we talk sometimes that when we don't trust our denominators, when we don't trust our admin data, we want to do surveys. But the surveys will rely on the vaccination cards, and really a big area of focus. If you can leave this session with one thing in mind, it's the data for action, and the action of the mother or the caregiver. It's really bring their baby back to the different sessions and to avoid missed opportunities. So the vaccination card is probably one of the most important areas. And then in the health facility, the name again, so you can figure out what dose is next. And at the end of the month, you can also identify children that were missed, that were supposed to be coming back, for example, or children who are, I don't know, turning 1 year old, and maybe they have missed some of their pentavalents, or they may have missed their measles vaccine, and therefore there's some active action that needs to happen to call them, to go to their house, to inform the community so that children can come back to be vaccinated. And this is really important also for women of childbearing age, for maternal tetanus, etc., because sometimes the women end up receiving 20 different doses because they don't get properly recorded.
Okay, thank you so much, Carolina. And I see Ahmed that's responding in the chat with satisfaction. That's very well answered. Thanks. Now there is a hand that has been raised for quite a while. Bashir Ahmed, Bashir, I'm going to invite you to unmute yourself. I don't know if you have a question for Carolina around this particular thematic area. If not, we are going to continue. So, okay, over to you, Bashir, and please start by telling us who you are, where you work, and what you do before asking your question.
Tout le monde. Bonsoir Carolina et tous les participants. Depuis Mauritanie, on vous...
Donc justement, d'abord, j'étais pas à la descente, j'avais pas accroché de la traduction, c'est pour cela beaucoup de choses m'ont échappé.
S'il vous plaît, Bashir, nous avons du mal à vous entendre. Est-ce que vous pouvez parler plus fort, s'il vous plaît?
Oui.
Est-ce que vous pouvez parler plus fort? Nous avons du mal à vous entendre. Donc, s'il vous plaît, allez-y, vous avez la parole. Oui, mais le volume est très bas chez vous.
Ok. Ce que nous réclamons, c'est l'équité vaccinale.
Ok, l'équité vaccinale.
Dans le tiers-monde, nous avons un problème, c'est l'accès au vaccin de manière équitable. Parce que nous, depuis la vaccination, notre taux de vaccin, on n'a pas pu atteindre l'objectif vaccinal. Non, on n'a pas pu atteindre 20% de notre objectif vaccinal. C'est grâce à la faiblesse des vaccins que nous avons reçus. Veillez sur ça. Merci.
Okay, merci beaucoup. Yes, Carolina, please. And I hope for English speakers, when the participant is speaking in French, you can also click on the little globe icon to hear the interpretation in English. À vous, Carolina.
Okay, so you ask about equity in vaccination, right? And I think that's crucial, and we need data to understand where we are being inequitable. Sometimes the normal information systems, the admin systems are not sufficient to really understand some inequities. So we need to use some other alternative sources of data. For example, to understand socioeconomic disparities, or inequities, to understand education of the mother inequities, etc. We normally use data from surveys. And what we know that children of mothers who are less educated, children of poorer households, they get less vaccinated. So now how can you target that? It's really then where you need to target your interventions and try to monitor them separately or targeted. For example, if you identify that a certain ethnicity of a group of people are more reluctant to get vaccinated for cultural reasons, for example, it's that then when the data has to be more targeted to understand that particular community, not only the quantitative data, like what's their coverage, but also a little bit on the qualitative side. And I think that's different, or the focus is different now with Immunization Agenda, that we want to go beyond understanding how much or how many people are missed to understanding why, and then understanding, are we doing better? And then if yes, great, continue. If not, repeat, why are we not doing better? And then do better and repeat. So I think that the issue of, again, inequality is first to identify them, understand the reasons, implement some strategy that you think or the evidence tells you that is going to help, and then monitor to see if actually improved. And again, surveys are great for diagnostic purposes, but not necessarily for implementing and following up. Then you really need more targeted approaches, more targeted engagement with the community, for example. Over. Charlotte?
Sorry, Carolina, I was muted. So I'm saying there are lots of discussions that I hear on the chat, and there's a question from Dobojena Admire. He says, national or provincial level generated population projections versus headcount of eligible children at health facility level are different. And as a result, it affects the health facility coverages negatively. How best can this be addressed? And there is Hawa Buhari that agrees with him, says, I totally agree with you, because this is one of our major issues in Northwest Nigeria. We are relying on projects from census conducted since 2006. So Carolina, could you respond to these concerns?
Yes, so the denominator is an old problem, and it's gonna get worse because people move a lot more than in the past. In urban areas, it's really a very population that comes in, they live, they stay, they move someplace else for better work. So what I would like to say here is that coverage is kind of an indicator of one indicator. And I think in this decade of vaccine, in the Immunization Agenda 2030, one of the key issues is not to focus just on one thing, not only on coverage, because coverage is going to be difficult to measure. It's really this idea of having to check yourself how you're doing, and also as a supervisor or through feedbacks, etc., to try to understand the situation using different approaches. So not only one measure, but really triangulate the data. If you think you're really well vaccinated and then you're having outbreaks, and then the cases are little children who never receive a vaccine, you have a problem. So one of the key issues here is not only focusing on one number, because in the past we were so fixated with reaching 80%, 90%, that people started even making up numerators just to make sure that they meet the goal. But in reality, now we are making more responsible, being more responsible to ensure that we are accountable to our population. So we have to look at different ways to see if our populations, they are covered or not. And the headcounts have limitations, so they are not usually accepted as the official denominator. But if in your rapid monitoring, for example, you identify many people missed, you have a problem. It doesn't matter if your coverage is 50 or 60, you still have a problem.
Okay, thank you so much, Carolina. And I see there are more and more questions in the chat. But before I return to the chat, we have Casimir Koloi, whose hand has been raised for quite a while now. Casimir, allez-y, activez votre micro pour poser votre question.
Oui, oui, bonjour, bonjour à tous. Bonjour à Carolina. Vraiment, j'apprécie son intervention. Elle a dit quelque chose qui a attiré beaucoup mon attention. Connaître la population cible et comment l'atteindre. Connaître la population cible et qu'on parle aussi, elle a parlé de la qualité des données. Et je constate que, en fait, le problème même de la qualité des données doit reposer aussi sur la population cible. Parce que dans nos régions, souvent, on a des dénominateurs, c'est-à-dire la population cible qui ne reflète pas souvent la réalité, ce qui fait un problème que nous vivons à chaque fois. Un district aujourd'hui, cette année, peut avoir 1000 enfants à vacciner. L'année suivante, selon ce qui se passe cette année, s'il a vacciné 1500, l'année prochaine, on lui donne une population qui va dans les 1500. Les recensements ne sont pas réguliers, ce qui fait que nous avons des difficultés à ce niveau-là. Alors, je me dis qu'en fait, quand on parle de la qualité des données, il faut parler déjà des données de base que constitue la population cible. Voilà un peu ce que je voudrais souligner à ce niveau-là dans son intervention. Alors, je me demande comment il faut résoudre ces problèmes. Souvent, on pense, moi je me dis, est-ce que dans un centre de santé, l'infirmier ou le personnel qui est là ne peut pas faire un recensement local pour connaître vraiment la population réelle à vacciner au niveau de sa zone d'activité? Voilà un peu mon intervention. Merci à tous.
Okay, merci beaucoup, Casimir. Carolina?
Okay, so the question really again comes to the denominator that all censuses, all projections, and what you vaccinate one year affecting what you're given next year, etc. And again, we are not going to solve the denominator problem anytime soon because people are moving a lot more. So what's happening in some countries, for example, it's the triangulation again. To identify first that you are sure that you know all the settlements of people where they are living. Because sometimes places appear and disappear where people move for work or migration during seasons. So some of the satellite images really are helping us estimate population size, or at least know when new settlements appear that may not be in your denominator, but you need to vaccinate. So it's really not going to be a great denominator. It's not possible with the technologies and the materials we have. Some of the head counts also have the problem of errors, and especially if you leave out an entire group of people for whatever cultural reasons or access. So again, looking at the different sources is where you can try to have a sense of where people are and then how many there are. Most governments are not going to accept a head count as the official because it's not the way statistics are done. But at your level, that can help you.
Okay, more and more questions. Meanwhile, we are gradually moving towards the end of today's lightning chat. There is this question from Kubanich Beck, Monolbaev, and forgive me if I don't get your name right, on DHIS2. He says, do you see added value of information platforms or tools such as DHIS2 in improving the data quality in countries? We are supporting implementation of DHIS2 in the country within a Gavi grant in order to improve data reporting at first instance.
So platforms like the HIS2 are really useful because they can help with the management of data. So at a lower level, you can have things digitized and you can graph data, etc. So you can have a better sense quicker if you are seeing anomalies in the data, if you're seeing outliers, if you're seeing consistent trends. But I think maybe more important than the tool, it's that the people who have to use it know how to use it and also use their thinking when looking at things, because we create tons of dashboards, we can create many of those things, but really if you're not thinking critically to understand when something is a flag and have the ability to act with that information, that now a tool, it's making it easier for you and more timely to see. If you don't have the possibility to act, or you don't pay attention enough to act, it doesn't matter if you're using an Excel thing or if you're using the HIS2. It's a great tool, but I would say it's really important to invest in the human resources that are going to be using the tool, so that some action can be triggered when through the tool you can see an anomaly in the data, for example.
Okay, thank you very much, Carolina. I want to turn towards another raised hand from Ndoutabe Modjirom. Ndoutabe Modjirom, if you can unmute yourself so that you can ask your question to Carolina, as that will probably be the last question that we are going to take for today, because we are almost out of time.
Merci beaucoup. Merci que je sois le dernier à poser la question. Non, réellement, moi je vis en zone forestière et nous avions eu, lors des différentes, je dirais, initiatives pour accroître la couverture vaccinale, d'énormes problèmes pour atteindre d'abord les populations qui vivent en zone forestière, parfois isolées. Et même ceux qui vivent le long des fleuves, et je prends par exemple le fleuve Congo. Pour les atteindre, ça demande d'énormes efforts, ne serait-ce que par les hors-bords, par les bateaux, pour aller atteindre peut-être les enfants qui sont vraiment, je dirais, isolés dans les forêts. Et ça a coûté énormément d'argent, je dirais, des ressources financières pour pouvoir les atteindre. Et l'impact est que on n'arrive pas à atteindre ces enfants. Maintenant, avec cette initiative 2030, qu'est-ce qu'on pourrait faire autrement, même si on arrive à localiser avec les satellites, là où les enfants et les parents habitent, il est difficile de les atteindre. Est-ce qu'au cours de cette initiative 2030, il y aura, je dirais, d'autres stratégies qui pourraient peut-être être conseillées aux gouvernants et ceux qui prennent des décisions pour pouvoir ne pas laisser pour compte ces enfants qui sont nombreux, je dirais, et qui malheureusement font les frais des différentes maladies évitables par la vaccination et qui sont vraiment... Merci, Caroline.
Okay, so the question and the example was about communities that are of difficult access, that you might identify with different ways, but really reaching them, it's really difficult and expensive. And I think this is the heart of the Immunization Agenda 2030, right? It's the equity. Yes, those populations are going to be much more expensive to reach. Yes, you will need to make more investments and in reaching them. But I think one of the areas here of importance is that you have to plan for them, and the funding, it's of course a problem. But what happens is these populations are usually the ones that the mothers don't get the antenatal care, are usually where the mothers are not vaccinated with tetanus. They are usually underserved in other aspects, not only immunization. So really the integration of interventions is probably the best investment. So that requires a stronger primary healthcare and organization. So it's not only about data, but it's about how that data can bring people together with other programs, with the malaria program, with the nutrition program, so that the resources are optimized when reaching them.
Okay, Carolina, you're actually muted. So thank you very much.
No, that's it. Mm-hmm.
It's okay?
Yes.
Okay, great. So we really do have to apologize to all those who have their questions in the chat and who raised their hands, and we are not able to listen to them today. As we said, and I see Reda has put in the chat, it's these are lightning chats, so 15 minutes at most. 30 minutes based on the number of questions that we have. So if you want to know more on this topic, we'll just refer you to IA2030.org to find out more about Immunization Agenda 2030, as well as the core principle that is focused on the topic for today, which was data enabled. And I want to thank Zah with sharing a link in the chat. We'll appreciate your feedback for this lightning chat. So please just click on the link. It will take you less, it's just 2 minutes, a few questions. We want to know how your experience of this lightning chat was and what we can do to make the coming ones better. So thank you so much for Carolina for accepting to come to join us today for this lightning chat and for answering all of our questions. We know that if there are links to more resources and information around this topic, we'll make it available to all those present using our various platforms. So we also want to thank our interpreter that has been with us interpreting to the French language. And I'll just turn over to you, Carolina, if there is a last word.
Thank you so much. And again, I think you are the creators of data in the countries. So it's where it starts. Remember, the vaccination cards are probably the most useful thing that sometimes we forget, the registries, and we start from there. Thank you. And goodbye.
Okay.
Happy evening.
Thank you very much. Thank you, everyone. And looking forward to seeing you tomorrow for another lightning chat. Bye for now.
Au revoir. Merci beaucoup.
Thank you.
Thank you. Unlike time.
Thank you. Thank you. Bye bye.
Au revoir.
Merci, Caroline.
Merci, Caroline.
Thank you so much.
Thank you.
Bye bye.
Beaucoup, Carolina. Merci beaucoup.